Thank you, Cindy. I don't have any relevant financial disclosures, but I do need to tell you that I have served as a consultant to a number of pharmaceutical corporations shown who manufacture products that could be used in the care of patients with the disorders I'm going to speak about, although I don't have a specific conflict. And I don't intend to discuss off-label indications because this is at the level of what is approved now, although I will mention areas that are under active investigation. So bone marrow failure, broadly conceived of, can be looked at the inherited and the acquired. The acquired is what we think of as idiopathic aplastic anemia related to medications, chemicals, toxins, viral infection, things that you get by history and careful physical examination, as well as paroxysmal nocturnal hemoglobinuria, which bridges a bit the acquired from the inherited or genetic. Then all of the inherited bone marrow failure syndromes on the right side of you, left side of your screen. We'll talk about each of these disorders mostly because somebody ought to, and this is really where they show up in the content specifications, literally saying usually know what they are. Then we will start out with actually the largest diagnosis of this whole group of things, which is idiopathic or immune aplastic anemia. But before we get there, why should we worry about all these weird, rare, inherited bone marrow failure syndromes, usually given the title IBMFS, because they're really not as rare as previously believed. They are under-recognized as de novo syndromes, as I think we've heard through at least the last talk, and they may represent as aplastic anemia or malignancy. The GATA1 mutation is probably a primary bone marrow failure problem with a malignancy superimposed on top of it. And the implications for treatment of not recognizing these syndromes is conventional treatments in patients with an underlying genetically unfunctional marrow have excess toxicities. These patients require different treatments for their bone marrow failure syndrome and definitely for malignancy. And when you get around to looking for a donor for hematopoietic stem cell transplantation, these are genetic disorders, so brothers and sisters need to be screened. And finally, something we rarely talk about, the implication for family planning. If two parents have already had a child with an IBMFS, subsequent pregnancies are also at risk. So throughout the talk, my content specifications will have this glaringly different type font, the italic in your handout, and the blue and red on your screen. I won't read them. They're there mostly so you know how to pin the information to the content spec. But they really are very broad content specifications. This isn't what I would teach fellows. This isn't what I would ask you to learn if you were learning about the disorder. But this is what the American Board of Pediatrics feels is important in the area of bone marrow failure. Starting with acquired aplastic anemia, the hematologic findings, and then recognize the causes we just talked about. So aplastic anemia, the onset's insidious. The patients usually have been sick, if you think about it, for 6 to 8 weeks because the hemoglobin has fallen by half simply by not making more. The patients are rarely have problems with infection or weight loss, fever, pain, adenopathy, lymphadenopathy, hepatosplenomegaly that you commonly see in malignancy. They do often present with isolated thrombocytopenia, and uncommonly, though, with clinical bleeding. The counts just aren't enough. Classically, it's important to know that the MCV is increased. That is one of those content specs you need to be aware of. High MCV macrocytosis, bone marrow failure, and a normal relative distribution width. All of the cells are just bigger than they ought to be. In addition, an elevated fetal hemoglobin is seen in most forms of bone marrow stress and failure. And although I don't think it's a test used very often anymore, the little I antigen is increased on the red cells. How do you define severe aplastic anemia? Well, Bruce Comita said it best, you can't compare treatments if you don't know what you're treating. So the Comita criteria are now used in the standard that you're seeing before you. You have to have 2 of 3 peripheral blood criteria, ANC platelets and reticulocytes below the specified values. 1 of 2 bone marrow criteria, cellularity being the sine qua non. Your cellularity needs to be less than 25% on a biopsy. You don't need 5 biopsies, just 1 that's less than 25%. Or if it is a more cellular marrow, the hematopoietic cells must be under 30%. There are other entities, very severe aplastic anemia with an ANC under 200, which you treat like regular severe aplastic anemia, and an entity of moderate aplastic anemia with an ANC above 500 that no one knows what to do with. So what are the causes of aplastic anemia? Now, this workup is usually negative because it's idiopathic. You look for radiation exposures. If they were at Fukushima, that would be a hint. Drugs, chemicals, toxin exposures, you get this by history. You need to ask not only what has the child been exposed to under the sink, what they got into from grandma or grandpa's medication bags, or more importantly, where grandma and grandpa or dad or uncle who lives in the home work because of clothing exposure that they bring into the home. You also need to look for viral causes. This is pediatrics, EBV, CMV, HIV, hepatitis, and HHV6 being the big actors. Parvovirus is a transient hypoplastic anemia, not usually aplastic. But there are other severe viral infections that have been associated with acquired aplastic anemia, meeting the criteria on the prior slide. Other disorders that are associated with acquired aplastic anemia, we're increasingly recognizing that autoimmune disease is an overlap with severe aplastic anemia. Immune diseases you may not think about, eosinophilic fasciitis, that's the cutaneous form, eosinophilic esophagitis, which we really don't know how that's interacting, and hypogammaglobulinemia or common variable immunodeficiency are clearly related to severe aplastic anemia. As is thymoma, again rarely seen in children, large granular lymphocyte or LGL leukemia, very, very uncommonly seen in children, but definitely associated and sometimes asked about. PNH we'll talk more about in a bit, and hypoplastic myelodysplastic syndrome masquerades as aplastic anemia, and it's sometimes very difficult to tease out. Hepatitis-associated aplastic anemia is a specific form that was very much in vogue when the content specs were starting to be developed in the 1990s, and so it is specifically asked about. Seronegative hepatitis is the cytopenias that are seen after the hepatitis resolves. So commonly it was recognized once patients survived severe seronegative hepatitis because of an orthotopic liver transplantation, and a number of large series have shown about a 30% incidence of hepatitis-associated aplastic anemia in seronegative fulminant hepatic failure. It has a high fatality if it is severe and unrecognized. It is probably not recognized as commonly as it occurs because most of the time the low counts get better as the newly transplanted liver starts to take. The treatment, same as idiopathic aplastic anemia. Hematopoietic stem cell transplant, yes, dual transplant on top of the liver, or ATG cyclosporin, as we'll get to in a minute, the immune therapy of aplastic anemia. Diagnostic evaluation for aplastic anemia, bone marrow aspirate and the word biopsy. Underlined words tend to be things worth remembering. Cytogenetics need to be done on the marrow, as well as FISH for MDS, at least for monosomy 7 and trisomy 8. You want to rule out the inherited bone marrow failure syndromes, and you're going, that was a huge slide 5 minutes ago. We really functionally look for those things that are common things being common and or suggested by history or physical examination. In the North American Pediatric Aplastic Anemia Consortium, we published a how we evaluate patients paper, and in that paper the majority of us recommend doing a chromosome breakage assessment on the peripheral blood with diapoxybutane or mitomycin C for Fanconi anemia, and a telomere length assessment because telomeres are going to be involved in cellular replication, and very short telomeres are associated with DC. An assessment for paroxysmal nocturnal hemoglobinuria clone, looking at the clone size by peripheral flow cytometry, ruling out the viral infections we talked about, EBV, CMV, HIV, parvo, because it might herald an early recovery, as well as hepatitis A, B, and C. As you saw, other hepatitis viruses are associated with this disorder, but not commonly enough in Western Europe and North America to make investigation worthwhile, and evaluation of renal, hepatic, and sometimes thyroid function depending on history. So what is idiopathic aplastic anemia? Well, we don't know, right? It's an aberrant immune response of some sort. It's increased in patients who are pregnant on a statistical basis and in those with rheumatologic disorders. We saw from the early days of transplantation the rare patient whose donor did not survive to donate, And we saw patients have a spontaneous recovery of blood counts after many years with the conditioning they received for their transplant that they didn't get. And this tells us that maybe immunosuppressive therapy would have a role. So we think what happens in idiopathic aplastic anemia is it's an aberrant immune response to all sorts of things. I gave you a lot of causes, but with a final common pathway of this immune response that's dysregulated. There is oligoclonal T cell expansion, cytotoxic T cells that mediate stem cell destruction and suppress the normal marrow. So get rid of the things suppressing the marrow, and the normal marrow should grow. And the things you want to get rid of are those inhibitory cytokines produced by T cells. So anti-T cell therapy should restore hematopoiesis, and to the extent that we can predict anything in aplastic anemia, the residual stem cells present at the time of treatment determine your likelihood of response with immune therapy. Immunosuppressive therapy is fairly well standardized. This is one of the few things that George Buchanan told me that hasn't changed in the last 35 years. The treatment is anti-human T cell serum. In North America, it's from the horse. In Europe, it's from rabbits. This contains a variety of anti-CD2 designated cells, although at the time we just knew you put human T cells in a horse and you got out something that seemed to work. You give ATG in a dose of 150 milligrams per kilogram per day or 40 milligrams per kilogram per day for 4 days. ALG's dosing is different. Consult the package insert. You provide steroids for 10 to 28 days to cover for the development of serum sickness, and cyclosporin, which prevents T cell proliferation, for about 12 months until the counts have been stable for about 3 months, and then you start to withdraw the medication. The role of cytokines, the GCSF that is ubiquitous in oncologic practice for neutropenia, is somewhat more circumspect here because of the concern for driving a damaged bone marrow stem cell towards MDS and AML. There is an emerging role, it is approved in adults but not in children, for the use of the topomimetic L-trombopag. And this disease, as well as in platelet disorders, it is likely that there will be an open trial through the North American Pediatric Aplastic Anemia Consortium, of which many of you have member sites, that will investigate the role of this drug in relapsed and de novo disease within the next year in children. There's also a small series of single-dose Cytoxan as immunosuppressive therapy. How does this work? Cyclosporin inhibits the proliferation of T cells through the mechanism shown. There are isolated reports of response to cyclosporin alone after ATG failure. It's certainly something to start using while you're looking for a stem cell donor if you did not transplant up front. Other immunoregulatory medications, FK506 and MMF, have been tried in very small series. They do block T cell activation by other mechanisms. They may stimulate hematopoietic colony formation, but they're just small enough that we still use cyclosporin because that was the first medicine that worked in the 1980s. What are the side effects of ATG? Again, a content specification, well, it's a horse or a rabbit protein, so they're allergic. And so we pre-treat with steroids, antihistamines, and meperidine for the rigors, slow the rate of infusion. You watch for serum sickness. Now, serum sickness is fever, a macular papular rash, myalgia, arthralgia, and any sort of symptoms you want, GI, CNS, or renal, as well as some myocardial symptoms, usually myocarditis or inflammation. It usually starts 5 to 10 days after the initiation of ATG, so in that first 2-week period. In addition, ATG, because it's truly an anti-T cell drug, gets rid of lymphocytes. You induce lymphopenia in this disorder and therefore put the patient at risk for pneumocystis jirovecii or PCP, and you need to think about prophylaxis while their lymphocyte count, something we normally kind of ignore in pediatric hemonc, is too low. Cyclosporin side effects are also something the board would like you to hear, and that's T cell inhibition, so PCP prophylaxis is an issue there too. But remember, our mainstays of sulfa drugs are marrow suppressive, particularly when used frequently, so you may want to consider alternative PCP prophylaxis if you decide to use it after that first lymphopenic period. Hypertension, hirsutism, gingival hypertrophy, nephrotoxicity, and the hypomagnesiemic problems that cause seizure risk are the other side effects of cyclosporin that are frequently asked about in this area. So, how does it work? Well, acquired aplastic anemia seems to have a short-term response of 80+%. 10 to 30% of patients go on either to need ongoing cyclosporin, which appears to be more prevalent in Japan, or they relapse and need additional therapy. The time frame for response is typically 3 to 6 months. Don't worry if they're not responding at 3 months, but if they're not responding by 6 months, you need to look for alternative therapy. Complete response normalization of counts is rare, but a partial response to transfusion independence and a lower infection risk because of a higher ANC is the rule rather than the exception in pediatric disease. However, you have persistent abnormal hematopoiesis after immunosuppressive therapy, and the risk for pediatric clonal disease, monosomies, trisomies, myelodysplastic syndrome, or significant PNH clones appears to be 10% at 10 years, although this is an estimate rather than the outcome of logical trials. But how do you compare that to the other therapy, hematopoietic stem cell transplantation, which will be covered in detail in another lecture, but both have 80+% transfusion independence. The difference is hematopoietic stem cell transplantation cures, IST, as we just talked about, does not because of higher rates of relapse and clonal evolution. There's also a very different shape of the disease-free survival curves, with IST having better 6-month survival because there is no regimen-related toxicity or very low regimen-related toxicity compared to that of a hematopoietic stem cell transplant. IST has a curve that continues to decline out to 6 to 10 years or longer. Hematopoietic stem cell transplants, except in the setting of chronic graft versus host disease for aplastic anemia, plateau after 2 years. The encouraging news is unrelated donor transplantation has consistently shown improving outcomes as we match better and treat better. There is higher non-engraftment and graft failure rates than with sibling donor transplant still, but this rate is rapidly closing. There's also the potential for somewhat reduced intensity conditioning because there's nothing there anyway, and you can get your grafts in better. So, how do you decide what's the way to treat? I think it's fairly safe to say that for the last 10 to 15 years, patients with severe aplastic anemia younger than 40 years of age, which in the bone marrow failure literature is young, do better with allogeneic sibling donor matched stem cell transplant than they do with immunosuppressive therapy. Unfortunately, many of our children don't have donors, so IST is a good second-line therapy if they don't have a sibling donor. And salvage therapy is available if they fail. Again, the North American Pediatric Aplastic Anemia Consortium has started a trial, Transit, to look at upfront unrelated donor transplantation versus IST in a head-to-head competition in a limited number of North American centers. So maybe 2 years from now we'll have something new in this talk. So where do we go from here? You need to understand the relationship between aplastic anemia, PNH, and malignant transformation. There is one. How it relates, no one quite knows. But PNH is a disorder predominantly of adults. However, it does appear de novo in childhood. It is an acquired stem cell clonal disorder with somatic mutations in the PIG-A gene. Throughout the talk, I'll give you the loci of the gene. I don't know if that level of detail is going to be questioned on the boards. In general, I don't think it will be, but the loci are there if you wish to know them. PIG-A functions in GPI anchor biosynthesis, and GPI covalently anchors glycoproteins to the surface of the cell membrane. If you don't have GPI-linked proteins, when complement attacks, it lyses the red cell. So, lack of GPI proteins leads to hemolysis at some level. How do you diagnose it? Nowadays, it's done on flow cytometry, which quantitates the percentage of GPI anchorage deficient cells, granulocytes, red cells, and other cell lineages. This has replaced a classic test called the sugar water or ham test, which I think is now of historic interest only, even though there were some questions at in some of the examinations a few cycles ago about the ham test. This PNH clone, as it grows, leads to hemolysis, hemoglobinuria, classically in the morning, and in fact you can see hemosiderin in the urine, and thrombosis. The venous mesenteric thrombosis of PNH is probably its most devastating effect. Hemolysis can cause iron deficiency. It occurs via the alternative pathway of complement. The boards want you to know that it is both intravascularly by complement and extravascularly as the opsonized erythrocytes are cleared by the RE system. So hemolysis and PNH, both intra and extravascular. But thrombosis is the leading cause of death. The risk is higher with a larger PNH clone. Clones larger than 50% is probably where this is a given. Clones between 5%, which may be normal under certain circumstances, and 50%, the risk of thrombosis is not linear, but it is clearly present. How you get the thrombosis is also not well understood. It may be from hemolysis with the free hemoglobin and nitric oxide depletion and platelet activation, something Dr. Newnard I know is going to steer clear of tomorrow in her platelet talk, or because of the GPI deficiency itself. Platelet activation, decreased fibrinolysis, so small clots don't get lysed. You lack tissue factor pathway inhibitor, you form bigger clots, and you get life-threatening thrombosis, sometimes or classically in the kidney. So, how does PNH overlap with aplastic anemia? Well, the classical presentation of PNH, overt hemolysis, increased reticulocytes, hypercellular marrow, you'll probably separate that out. But where PNH clones occur in aplastic anemia, a small one at diagnosis may be associated with a better response to immunosuppressive therapy. You have scant overt hemolysis, hypocellular marrow, but severe cytopenias in PNH-positive patients, even if it's classical PNH, may also respond to immunosuppressive therapy. And after immunosuppressive therapy, you may have a new clone appear, but unless it is symptomatic, it is simply something that needs to be followed. But this is probably the most common second problem after IST for aplastic anemia. So the long-term follow-up of an immunosuppressed patient should be at least an annual clone size assessment for PNH. How do you treat it? Treatment that is curative is, of course, transplant, but that is usually reserved for patients with severe pancytopenia and life-threatening thrombosis. In the last 5 to 7 years, eculizumab, which is a humanized anti-CD5 monoclonal antibody, has become the treatment of choice for symptomatic PNH. A clone, no matter how big, if the patient is not having problems, does not require treatment. What eculizumab does is reduce red cell hemolysis and has been shown in a lot of studies to increase the quality of life by decreasing fatigue. It also appears to reduce the thrombosis risk. It has a lot of side effects, and before you use the medication, remember that it gets rid of complement's ability to clear the immune system of pathogens. So Neisseria meningitidis infections have been reported, and so that vaccine becomes very important. So we move from acquired idiopathic to inherited. They're also called constitutional or familial aplastic anemia. They are frequently associated with physical abnormalities, and I think that's the way most of us learn them. The anomalies, however, are not always obvious or present, as we'll see in a few minutes. Hematologic findings may or may not be present at birth, and they may not present until adulthood. There is clearly an association with an increased frequency of cancer. The most common kind of cancer is actually squamoepidermal carcinoma, and the most common bone marrow problem is myelodysplastic syndrome, which transitions very smoothly in some patients and not others to acute myeloid leukemia. The presenting sign of the bone marrow failure, however, may be the malignancy. So the clinical features of the most common inherited bone marrow failure syndrome, which is Fanconi anemia, is macrocytosis, which progresses to pancytopenia. Congenital anomalies we'll see on the next slide are not always present, may be subtle, and not required for diagnosis. This is a cancer predisposition syndrome, and the cancers are AML, squamous cell carcinoma, and certain subtypes of Fanconi anemia are actually at risk for solid tumors, including brain tumors. So I was diligently sitting in the back of the room trying to learn from our 1 o'clock speaker. The other way you make the diagnosis is family history. And if you think that, oh, I'd never miss a history of Fanconi's, well, I found out last night that a patient I've been following for 2 years for a horrible vascular anomaly, her father's leukemia wasn't really. He actually has Fanconi anemia, and the family never knew. So always ask, and then if you have any suspicions, verify. The congenital anomalies in Fanconi anemia are quite numerous. We all are well aware of radial ray anomalies, skin anomalies, both cafe au lait brown spots and hypopigmented ash leaf lesions, short stature, genital anomalies, eye anomalies, renal, cardiac anomalies. None are specific, and they are not always present. The hands, however, are the classic anomaly. They are primarily radial ray deformities. They are starting at the distal part of the radial ray, so if the thumb is normal, don't worry about the rest of it. If the thumb's not normal, anywhere up this preaxial border may be abnormal. It is bilateral in 50% of the children who have them. The ulna may be thickened, given sort of a rotational left-handed curve appearance to the way that the arm looks. Just the thumb alone may be hypoplastic, because remember they start distally. You also want to look at the scapula and the thenar eminence, because sometimes you'll see something faintly abnormal there and see that there really is something that makes you say, I really want to know the results of the test. And what test do we do? Well, Fanconi is a DNA repair defect. You get increased chromosomal breakage, but not in standard karyotypes. You need to do a peripheral blood karyotype with or without exposure of the cells to a breakage-inducing agent. The most common breakage-inducing agents are diapoxybutane and mitomycin C, and you basically send the test off. There is a warning about commercial laboratories. You need to know to whom they send the test, because many of the major commercial laboratories send the test to themselves and then spend a week or two sending these very damaged cells around the country, and the result you get is no growth. So if you get no growth and you really want to know, you can consider doing skin fibroblasts or having your laboratory directly contract with a lab that does the testing itself, to whom you can send the cells without their frequent flyer-inducing journey. It can also be done by a clostridine-induced G2M arrest pathway in a flow cytometric assay, but that is not the standard way. And most people who are the honchos in the Fanconi anemia field feel that the peripheral blood karyotype is a more sensitive and specific diagnostic test. You diagnose the disease based on clinical history and the results of the chromosome breakage. You get a specific mutation analysis to help you understand what type of Fanconi anemia you're dealing with. On your screen on the left-hand side are normal, happy chromosomes. Those normal, happy chromosomes attacked by diapoxybutane on the right break, don't line up the way they should, and form something called a radial formation that is also the hallmark of a chromosomal breakage syndrome. How common is this? 1 in 300 people in North America and Europe are felt to carry one of the Fanconi anemia defective genes. Not a lot less common, actually, than cystic fibrosis in the Caucasian population. In certain populations, Ashkenazim and Afrikaans, it's actually even higher. Complementation studies have shown us that there are 16 at least subgroups of Fanconi anemia. They're lettered A through Q, I guess now. Many have just one patient in them. The Fanconi anemia proteins are all nuclear proteins in a complex that repairs DNA. The mutation analysis is important because although most patients, about 60%, have mutations in the FANC-A proteins and 10% or so in FANC-C, there are many other groups, including a few patients who we all think have Fanconi anemia, but we haven't been able to prove what type. Why do we care? FANC-C is associated with a more severe course, but FANC-A, the more common one, is associated with a later onset of bone marrow failure, starting about age 4. FANC-B and D1, which is the BRCA2 gene, have a very early onset of myelodysplastic syndrome and AML, and FANC-D1 and N are the two types associated with solid tumors, D1 with Wilms tumor and N with medulloblastoma. These are the mutations. The part in blue is the only Fanconi anemia gene, which is FANC-B, that is not autosomal recessive. It is X-linked recessive, fortunately very rare, but remember, associated with a very rapid onset of bone marrow failure. What are our therapeutic options? Well, for all of the bone marrow failure syndromes, the first thing we're going to talk about is supportive care, because this is a diagnosis from birth. Therapy is related to what the patient manifests rather than the presence of the genetic change itself. Management of the congenital anomalies. You want to take care of the heart defects, the renal defects, the orthopedic problems before thrombocytopenia limits your surgical options. You want to transfuse with the fewest units you possibly can, and you want to irradiate them from diagnosis, because all of these patients, like all oncology patients, should potentially be considered candidates for hematopoietic stem cell transplantation. The role of growth factors used to be more robust here, but you have a damaged marrow, and do you really want to drive it with pharmacologic doses of G or GM-CSF? Fanconi anemia patients have taught us that you need to monitor their marrow for problems. Most people recommend an annual marrow, watching the peripheral blood counts and stepping in and looking both at cellularity, cytogenetics, and morphology at least annually. My little ones, sometimes they get out to 18 months because their counts are still pretty normal, but once the counts fall, it's a reassuring way once a year to say, right now, there's nothing that looks like we're headed down the wrong pathway. If you wish to support the counts, there's also the use of androgens. These may slow the count decline, but they will not usually stop the development of aplasia. Danazol, which is less virilizing, is used sometimes in girls, but probably is not as effective as oxymethylone. Hematopoietic stem cell transplant is curative, and with reduced intensity conditioning mandated by the DNA repair defect, patients do actually do well. However, this causes secondary problems that we'll talk about in a moment. You also have to remember that it's a genetic disease, so a sibling donor, which would be your best donor, may also have the disorder, which is why you want to know the complementation group, or at least do a stimulated chromosome test looking for chromosome breakage before doing the transplant. And very encouragingly, the survival of patients with unrelated donor transplantation is beginning to approach that of sibling donors. Androgens, well, they're androgens. They virilize. 8-year-old boys think it's really cool to have a mustache. 12-year-old girls are not quite so impressed. They do have a growth spurt followed by premature epiphyseal closure, making the short stature of the disease even more pronounced. Hyperactivity and behavioral changes, but the problem that the board would like you to know about is that androgens can cause cholestatic jaundice or transaminitis, but they also are associated with the development of either Pileosis hepatis, which is a very peculiar blood lake phenomenon, which can rupture, leading to intra-abdominal bleeding, or to hepatic adenomas, which can become malignant or also bleed into themselves. Therefore, it's recommended that anybody on androgens to support their counts should have annual hepatic ultrasound and probably quarterly to semi-annual liver function tests looked at by a hematologist. However, if you're going to think about treating this disorder, look at all your treatments, androgens and transplant, in the same breath, and decide with that family which way they wish to proceed. Malignancy in Fanconi anemia is real. The risk is about 1,000-fold in excess over age-matched populations. 1/3 of the patients develop malignancy by their adult years, their 20s to their 30s, and death usually comes within the 4th to 5th decade. Clonal abnormalities are present in the marrow of up to half of the patients at some times during their lives, but we have learned that these clonal abnormalities, even monosomy 7, wax and wane for periods of at least 10 years. So just because you get a clonal abnormality, if you don't have a myelodysplastic marrow, that may not be an indication to move on different therapy for your patient. 10% of the patients get leukemia, 10% get a solid tumor. There's mostly the squamous cell carcinomas of the head and neck, the liver tumors we talked about, and female FA patients are at very high risk for genital tract malignancy, including vulvar, cervix, and vaginal neoplasms in their late teens and early 20s. These risks are all massively increased by hematopoietic stem cell transplantation. The squamous cell carcinoma risk may be 4-fold increased. The solid tumors come 16 years or half a lifetime for these patients earlier. And that solid tumor risk is increased further by chronic graft versus host disease and the inflammation that it causes. The other risk is once you get the malignancy, you get excessive toxicity if you try to use standard treatment regimens, so surgery is the mainstay of therapy. But FA is often diagnosed after the treatment for malignancy because the patient has increased toxicity. So suspect an underlying inherited bone marrow failure syndrome, such as FA, if the toxicity of leukemia therapy, AML therapy, that dose of anthracycline, is early and unexpectedly severe. Early diagnosis of the progression to MDS and then AML allows for you to review the options for therapy with the family and search for the best unrelated donor if that's the treatment you wish to select. Dyskeratosis congenita. This is another really common bone marrow failure syndrome. It is also extremely difficult to understand and diagnose in childhood. It's a triad of ectodermal dysplasia, of showing you reticulated skin hyperpigmentation, dystrophic nails, and mucous membrane leukoplakia. They do develop with age, again in the second and third decades, but they may not be present. Aplastic anemia develops in up to 50% of patients, at least moderate aplastic anemia, again in adulthood. Solid organ cancers occur in the third and fourth decades, again a mixture of AML and carcinomas. The classic things to remember with dyskeratosis congenita is bone marrow failure associated with pulmonary disease and with early graying, the very striking gray forelock that we see in Chiari-Akagashi and other syndromes will be seen in dyskeratosis congenita as well. These are the other features. The genetics, 3 patterns of inheritance: autosomal dominant, almost never seen in Fanconi anemia, autosomal recessive and X-linked. The hallmark is very short telomeres. That's why this is the test we recommend you send in addition to the bone marrow chromosomes with DEB. All of the genes in dyskeratosis congenita are in the telomerase complex, and telomeres are very, very special protein DNA complexes at the end of chromosomes and responsible, if you will, for telling the chromosome that it's going to be okay, you can divide, and the next generation will be very happy. You don't have that, your cells age because their telomeres become extremely short. Dyskeratosis has at least 8 known genes. As you see, if you add up the frequency column, we don't even get close to 100%. The genetics are everything you can think of, but there is autosomal dominant here. And they're all parts of this complex at the end of chromosomes. Many DC patients lack mutations that we know of yet, and we're likely to identify more. How do you diagnose it? Clinical features and family history. If mommy tells you she has it, that's probably the only for sure clear clue you've got. You don't need the classical triad, you don't need the physical stigmata, you need an index of suspicion. The telomere test will give you very, very short telomeres for age, less than preferably the first percentile for age in more than 3 lymphocyte subsets. Genetic testing can be used, but as you see, if you get a negative genetic test, maybe they're in the 40% that we don't have the gene for yet. How do we treat? Supportive care. Most of these children have no trouble whatsoever or mild cytopenias, simply requiring education and monitoring. Androgens and cytokines can be used, but in DC there is a very real risk of viscous rupture, predominantly the spleen, with higher doses of androgens. Again, you watch and monitor carefully if that's the therapy you select. Hematopoietic stem cell transplant can be used, but again, reduced intensity regimens are needed. The pulmonary toxicity that is part of the disease is often brought out by the transplant, and there seems to be an increased risk of veno-occlusive disease that nobody seems to understand. Now switching gears from the 2 really bad things to the one, if you have to choose one of my disorders, this would be the one I'd choose. And that's called Diamond-Blackfan anemia. Now in this disorder, the parent support groups got a bunch of experts together and said, what do you look at to make a diagnosis of Diamond-Blackfan anemia? Well, young children less than a year of age with a macrocytic anemia, reticulocytopenia, and a paucity of erythroid precursors in the marrow are pretty good criteria. There are also a number of supporting criteria. Again, a positive family history. That's always really helpful if dad says, I had it too. And a pathogenic mutation. However, like in all the other disorders, we do not have all the genes yet, and the majority of patients we do not know. We know the majority, rather, but there is a significant minority, about 40% across all of these disorders, that don't yet have a genetic mutation that for which is causative for their disorder. The other minor criteria, elevation of something called erythrocyte adenosine deaminase, congenital anomalies, an elevated fetal hemoglobin also seen in most marrow failure syndromes, and nothing else you can think of support a diagnosis of DBA. Classic DBA, you have all of the diagnostic criteria, and non-classic DBA, you have a mixture of everything. If you wish to know more, read the paper, because it isn't clear, but these are things to think about. At least half of the patients have congenital anomalies. Their congenital anomalies are very, very similar to the other disorders. Tow-colored hair, wide-based nasal bridge, thumbs, which can be subtle, genital urinary problems, and cardiac problems. More than 20% have more than one anomaly. Short stature and bony abnormalities are very common and frequently overlooked. These patients not only have reticulocytopenia and a paucity of red cell precursors, they may have neutropenia if you look carefully, and rarely thrombocytopenia as well. I've only been about 6 patients reported that I know of to the Diamond-Blackfan anemia registry that went completely aplastic, but it's a possibility. Genetics, autosomal dominant, may be sporadic or inherited, lots of mutations, but the mutations are all in ribosomal proteins, both large and small. 40% we don't really know the mutations, and they're all involved with the assemblage of proteins from amino acids. So if you will, the powerhouse of the cell doesn't work right. You have defective erythropoiesis resulting from this haploinsufficiency, and that's really the most well understood of the bone marrow failure syndromes. How do we treat this? Diamond-Blackfan is a really odd disease because it responds to prednisone. In many patients, up to 80% at some point of their lives will respond to prednisone. We start at 2 milligrams per kilogram per day, and we give a trial of at least 2 to 3 months before we say it's not working. But if you haven't stopped the need for transfusions, if you haven't been able to maintain a hemoglobin of 9 after 3 months of 2 per kilo per day, stop, because they're not going to respond to prednisone with a prolonged course. If they do start to respond, taper the dose of medication to the lowest dose possible. Most patients require 1 milligram per kilogram per week or less, divided into 2 or 3 doses. For patients who are steroid refractory or those who require a higher dose than that, consider chronic red cell transfusions. And for very young children, up to the first year of life, we actually do give chronic transfusions once every 28 days to maintain a hemoglobin of 9 because of the high risk of pneumocystis with that kind of prolonged steroid therapy in infants. The risk of transfusion, of course, iron overload, which will be discussed, I'm sure, more in the next talk. Outcomes? 100% of the patients, 80% will respond to steroids at some point in their life. 20% of patients will get rid of the disorder. They'll have a macrocytic anemia, but they'll maintain a hemoglobin greater than 9 with or without steroids for a lifetime. Unfortunately, there is no predictive genetic or clinical features who tells me he's going to have a spontaneous remission, who will remit and then relapse during adolescence or pregnancy. Patients who need to be on chronic transfusions or on high doses of steroids, again, hematopoietic stem cell transplant is an option. This is particularly true for those patients who become alloimmunized or become pancytopenic. Again, it doesn't cure a solid tumor risk, and you need to look at the sibling for careful evaluation for DBA themselves. DBA malignancy risk is lower. The best review, again, the same paper from Alter and Shimomura, says that half of those patients have AML and MDS, but we notice this is just 30 patients in the literature. The other unusual malignancy that this group of patients develops is osteosarcoma. Board makes a lot out of the differential diagnosis of pure red cell aplasia, both Diamond-Blackfan versus transient erythroblastopenia of childhood. This is the differential of pure red cell aplasia. Why do your red cells not get made in childhood? It's there mostly for your reference. How do we compare the two big actors? Well, we talked about Diamond-Blackfan and inherited bone marrow failure syndrome versus transient erythroblastopenia of childhood, which is acquired. DBA children are more likely to have physical anomalies. But please notice, if you want to look at the counts, there are no difference in reported series. Both have low hemoglobins, but again, anywhere from 10 to 50% of the patients either have very low or very high platelet counts and a very low ANC. These are bone marrow failure syndromes. one of the things you can do early on in Diamond Blackfan before the first transfusion is to look at the erythrocyte adenosine deaminase, as we talked about earlier. It will be elevated in DBA and normal in TEC, but they both will be macrocytic, particularly during the recovery phase, and fetal hemoglobin as a sign of marrow damage will be elevated if you measure it. It's probably not clinically helpful, however. How do you separate these things from an aplastic crisis in hereditary hemolytic anemia? Well, if you know they have HS, it's pretty easy. But if you haven't made the diagnosis of a hereditary hemolytic anemia previously, and you have a patient with a low hemoglobin, a biggish MCV, and a very low reticulocyte count, it can be difficult. Remember that an aplastic crisis is usually triggered by a viral infection of which there may be other signs, frequently parvovirus B19, but HHV6 has been implicated. You may get a 10 to 20 day reticulocytopenia as consistent with most viral syndromes, but there certainly have been well-documented cases of reticulocytopenia with parvovirus lasting over a year. Counts improve as the patient recovers from the infection, but until you have the patient's counts recover, it's very difficult to tell the difference between TEC and an aplastic crisis of a hereditary hemolytic anemia. TEC is something that was really pushed in the content specifications. I think if you know a little bit about it, it would stand you in good stead. Remember, this is the spontaneous cessation of erythropoiesis in an otherwise healthy child. It can involve neutrophils and platelets being low. Usually it's self-limited. Transfuse if the counts are very low and follow it to resolution. If it doesn't resolve, loop back up and see if you missed something. Otherwise, you're chronically transfused, you have anemia and neutropenia. I think a marrow is going to give you your answer. Pearson syndrome is also something the board mentions. This is another very strange bone marrow failure syndrome. It is actually a refractory sideroblastic anemia associated with exocrine pancreatic dysfunction and fat malabsorption. It's associated with mild neutropenia and thrombocytopenia, usually presents in very young children who it doesn't make sense what they have. You do a bone marrow. You get vacuolated precursors, sort of looks like a B cell, Burkitt type cell in the precursors in the marrow. And if you do an iron stain, you'll get ring sideroblasts in the marrow. Death is usually a consequence at an early age of acidosis, sepsis, and liver or renal failure, and the median survival is quite low. Although some children with Pearson syndrome appear to survive into adulthood, and it appears that the deleted mitochondrial DNA actually starts to reform, and the amount of the deletion gets smaller with age. It's a very unusual disorder. Because it's mitochondrial DNA, the mother is the one who gave the child the gene. Shwachman-Diamond syndrome. Believe it or not, that is not part of the content specifications in this portion of the board thinking. It will be in subsequent versions. It's discussed briefly in the neutropenia section or the leukocyte disorder ones tomorrow. But I think it's an important thing to look at in the same fashion as we've been looking at the other bone marrow failure syndromes, just so it's all together. Shwachman-Diamond syndrome, same Dr. Diamond, Lou Diamond from Boston. In this case, it's a hematologic disorder with fluctuating neutropenia, usually from birth, and white cell dysfunction, impaired chemotaxis. Anemia is present in a third, thrombocytopenia in 20%, again, bone marrow failure. Aplasia develops in 10 to 25% of the patients, and again, the evolution is through myelodysplastic syndrome and AML. This is a disorder, though, of neutropenia and exocrine pancreatic insufficiency. So Shwachman and Pearson's are the two with pancreatic problems. But transaminitis here is more of a problem. Many of these patients are first seen by gastroenterologists who will do workups of low trypsinogen, pancreatic isoamylase, fecal elastase when these are measurable. Some of these tests are used so rarely that they are not commercially available in North America anymore. And they can see a fatty pancreas on imaging. Patients may have metaphyseal chondrodysplasia, a characteristic asphyxiating thoracic dystrophy or bell-shaped chest. They're short, they have eczema, cardiac, endocrine, and renal problems. Sounds like kind of everything else, but the hallmark here is neutropenia and pancreatic insufficiency. The differential diagnosis, as you suspect, would include cystic fibrosis, and Dr. Shwachman was a gastroenterologist, also at Boston Children's, and the two of them said, I have these group of patients that should have cystic fibrosis but don't. Severe congenital neutropenia would be in the differential, as would be Pearson's. It's autosomal recessive, there's a male predominance, but 90% of these patients have the same genetic mutation in the SBDS gene on 7 centromere. And it functions in ribosome biogenesis. So the two ribosomopathies, Diamond-Blackfan and Shwachman-Diamond. How do we treat them? Fix what's wrong with them. They're missing pancreatic enzymes, they're missing vitamins, we give them back. You manage the congenital anomalies. If they're neutropenic enough to be having gingivitis or infections, GCSF, lowest dose possible, least numbers of days per week, fewest transfusions possible, and again, particularly in those patients who need GCSF, periodic, we would usually say annual bone marrows. Stem cell transplantation has been required in a few patients, and again, probably there is some modification of the conditioning regimen that will be required. Amegakaryocytic thrombocytopenia, we're in the home stretch now. Amegakaryocytic thrombocytopenia is an autosomal recessive disorder. It is a mutation in the c-MPL gene, which is the thrombopoietin receptor. Bone marrow, Diamond-Blackfan, you're missing red cells. Amegakaryocytic thrombocytopenia, you're missing megakaryocytes. These patients are usually thrombocytopenic at birth. Their red cells are macrocytic. Again, they're named for one cell lineage, but it is truly all cell lineages that are involved. So they're macrocytic red cells with an increased fetal hemoglobin. The platelets look normal, so you won't be starting to think Wiskott-Aldrich, which would be the little tiny platelets. Very high risk of degenerating from MDS to AML. There are two phenotypes of this disorder. The majority are in the early phenotype, which is early bone marrow aplasia, and that correlates with a specific mutation and the amount of c-MPL activity. CAMT, although it's only applicable probably to the 80% that are early phenotype, is treatment by hematopoietic stem cell transplantation. These patients become rapidly sensitized to platelets, and so transplantation is usually between 6 and 12 months of life. The confounder in all of this is something called the thrombocytopenia and absent radius syndrome. Long before Toni Morrison called it, we took care of TAR babies too. TAR babies have an autosomal recessive disorder. It's due to a gene mutation in RBM8A, which is an RNA binding motif protein. On chromosome 1, same chromosome that's involved in CAMT, but the other half of it. Typically, one allele carries a deletion and the other one has a mutation. Thrombocytopenia present at birth. So two disorders, thrombocytopenia present at birth. What's the difference? Thrombocytopenia with absent radius children are missing their radii. And the hint here, which also has shown up in some questions I've seen over my career, is in Fanconi anemia, remember the defect is terminal. Your thumb is going to be abnormal if anything else is. In TAR children, the thumbs are usually present, and it's the radii that are abnormal, which is one way when you look at the child at the bedside, you can start to breathe a little easier or know that you're really in for it with Fanconi anemia. In TAR, it's also common that these children have leukemoid reaction early on or with subsequent infections. They can also get hypereosinophilia. They have GI problems, and GI bleeding from milk protein intolerance is a common phenotype. Facial abnormalities, but lower limb abnormalities also in 40% of them, so absent radii and lower extremity abnormalities, think about that. And 10% have congenital heart disease. 2/3 of them do outgrow their severe thrombocytopenia by a year of age, but contrary to what I think most of us were taught early on, most of the platelet counts aren't entirely normal, and 1/3 of them don't get better. So again, how do you want to take care of them? Work on the congenital anomalies as soon as you can, and you don't know yet whether they're going to be one who's going to recover their counts at a year of age, but if they haven't, then you need to proceed to the orthopedic reconstruction of those upper extremities and lower extremities if needed for functional lifetime. Transplantation is curative, but it's not usually required. And so, this has been a whirlwind tour through very rare diseases which most of us will never see. There are even 1 or 2 of these I haven't seen yet, and although I've been looking. There's the presence of characteristic physical anomalies along with the hematologic anomalies that will guide your thinking. Unexplained macrocytosis in a patient with or without characteristic birth defects needs to really get your attention, as do children who have aplastic anemia and myelodysplasia. Is this really an undiagnosed inherited bone marrow failure syndrome? Because therapy will be different. Patients who are diagnosed and starting treatment for a malignancy who have highly complex courses because they just have a lot of toxicity with chemotherapy or radiation therapy should also make you double back and wonder, am I dealing with a patient whose stem cells were not normal before the malignancy developed? Also, patients who develop specific cancers at an early age, again, usually young adulthood, head, neck, and esophageal cancer in patients under 40 years of age, particularly those who do not smoke or use tobacco products, or vulvar cancer in women under 30 years of age in our family history, should make us think at diagnosis of a malignancy, is this an IBMFS? And frankly, any family member that has anything, you really do wind up having to explore. Thank you for your attention.